Hello learners, in this video we will be dealing with the pubertal development and primary amenorrhea, its diagnosis and management. So the stage of puberty is divided into four parts. Beginning of the growth spurt, then occurs thylarch or the development of breast, pubarch, that is development of pubic hair, and menarche, which is the occurrence of menstrual cycle in a pubertal female. So this is the Tanner's staging for thylarch. There are 5 stages. In stage 1, the breasts are prepubertal. Breast birth develops in stage 2 with elevation of the breast and the papillae, and there is enlargement of areola also. So in this stage, both breast word will lead to the development of breast and the papilla, and areola also enlarges. In stage 3, further enlargement of breast and areola occur, but there is no separation of their contour. In stage 4, areola and papillae form a secondary mound above the level of the breast. In stage 4, a secondary mound is formed. In stage 5, mature stage with projection of papilla only and related to the recession of the breast development. So this is the Tanner's staging for pubarch or the development of pubic hair. In stage 1, the pubic hair are present and they are between the vellus hair on the mons and the anterior abdominal wall, and there is no pubic hair. While in Tanner's stage 2, there are sparse, lightly pigmented hairs with minimal curls on the labia. In Tanner's stage 3, hair becomes darker, coarser, and begins to spread over the junction of the labia. In Tanner's stage 4, adult hair types are seen covering the mons pubis but does not extend to the thigh. But in Tanner's stage 3, adult hair pattern is seen, and in this adult hair type in the classical female pattern means covering the mons and thighs also is present. So this is the occurrence of menarche. Menarche is the first menses that occurs in a pubertal female, and this is the HPO axis which is responsible for menarche. So what happens? Hypothalamus is releasing GnRH, which is a gonadotropin releasing hormone acting on the pituitary to release LH and FSH, which are follicular stimulating hormones and luteinizing hormones respectively. These LH and FSH acts on the ovary to produce estrogen and progesterone, and there is negative feedback also through inhibin progesterone and estrogen, mainly estradiol levels. Theca cells also releases androgens which also inhibit pituitary as well as the hypothalamus in a negative feedback pathway. Now this estrogen, which is estradiol, is responsible for breast development, growth acceleration and skeletal maturation in a pubertal female, and this estrogen and progesterone leads to menstruation. This is 2-cell 2 gonadotropin theory, means for menstrual cycle to occur we need 2 cells and 2 gonadotropins. First cell is the theca cell and the second cell is the granulosa cell, while 2 gonadotropins are the LH and the FSH. So what happens when LH binds to LH receptors? It forms the androstenedione, which is a androgen secreted by the theca cell. This androstenedione enters the granulosa cell, and under the effect of aromatase enzyme, this androstenedione is converted to estrione, and then through 17 beta HSD estradiol is formed, and then this estradiol is released into the circulation. So this stimulation is carried out by follicular stimulating hormone. Here we can also see an image of the follicle where there is the secondary oocyte within the follicle, and then there is basement membrane followed by theca interna and externa, and a granulosa cell layer is also covering the follicle. Now there is amenorrhea. What is amenorrhea? It is the abnormality of menstrual cycle, and this is manifested by the absence or cessation of the menses. This can be primary amenorrhea, in which a female has never experienced menses, or it could be a secondary amenorrhea, means previously her menstrual cycles are regular or normal, but now her menses has stopped. So how will you define primary amenorrhea? Primary amenorrhea is the absence of menses by the age of 13 years with no secondary sexual characteristics. So if there is no secondary sexual characteristic, then age of 13 years is taken, and in the presence of secondary sexual characteristic, we can wait till 15 years of age for the menses to occur. So this is the etiology of primary amenorrhea, also known as Spiroff's compartmentalization, in which the HPO axis is divided into 4 compartments, and based on the etiology, we have divided it into compartment wise. So compartment 1. What is compartment 1? Compartment 1 is considered as the outflow tract and the uterus. So if there is outflow tract obstruction or there is any anomaly within the uterus, then this is compartment 1, and this is characterized by certain syndrome which can cause compartment 1 primary amenorrhea. This includes MRKH or Mayer-Rokitansky-Kushner-Hauser syndrome, which is also known as MRKH, in which there is no formation of uterus, fallopian tubes, cervix, etc. Then comes androgen insensitivity syndrome, imperforate hymen, where there is outflow tract obstruction, and transverse vaginal septum can also be the cause of primary amenorrhea. In compartment 2, there is gonadal dysgenesis, means the cause is ovarian. This could be due to Turner syndrome, Sware syndrome, or the gonadal failure. Compartment 3 includes tumors or conditions which can affect the pituitary gland, and these are hormone secreting adenomas, non-functioning adenomas, tuberculosis, sarcoidosis, etc. Compartment 4 is hypothalamus. It could be due to constitutional delay, malnutrition, anorexia nervosa, vigorous exercise, stress and anxiety, drugs like antipsychotic drugs, genetic cause like Kalaman syndrome, organic diseases, tumor and infiltrative lesions. So these can lead to hypothalamic amenorrhea or compartment 4. So as we all know that estradiol production is important for breast development or the thylarch, and this estradiol is formed in the granulosa cells under the effect of follicular stimulating hormone. So American Society of Reproductive Medicine, also known as ASRM, classified primary amenorrhea into 3 types, where first one is that where there is development of breast, and this can be seen in Mullerian agenesis or MRKH syndrome, androgen insensitivity syndrome, vaginal septum, or the imperforate hymen, mainly in those cases where there is compartment 1 diseases. If there is no breast development but the FSH level is very high, then the problem is occurring at the level of ovary, and the incidence is 40%. The causes are Turner syndrome, gonadal dysgenesis 46XX, and gonadal dysgenesis 46XY. Now if the FSH is low, means the problem is arising from the hypothalamus and there is no menses, no breast development. This can occur in compartment 3 or compartment 4, and the cause can be constitutional delay, Kalaman syndrome, other CNS lesions, stress, weight loss and anorexia. Now, how will you evaluate the patient for amenorrhea? First important factor is patient's history. So we have to take a proper history of the pubertal development, when the thylarch has occurred, when the pubarch has occurred, and premenstrual symptoms, if any presence of dysmenorrhea or cyclical abdominal pain, which can be seen in cases of compartment 1. Past medical history like chronic illness, exposure to radiation, current medication history is important, history of excessive weight loss, exercise, illicit drug use important, and family history of pubertal delay, which can justify constitutional delay, history of infertility in the family, and we also have to review the systems for anosmia, as in Kalaman syndrome, galactorrhea, where the cause is found to be pituitary in origin, headaches, visual changes seen in pituitary, prolactinoma, hirsutism and acne like in PCOS, and sign and symptoms of thyroid disease. So hypothyroidism and this PCOS can cause both primary amenorrhea or secondary amenorrhea. Now we have to do physical examination, in which we have to see the growth charts and take the BMI of the patient. Secondary sexual characteristic assessment based on Tanner staging, breast development and pubic hair is important. Dysmorphic features like webbed neck, as seen in Turner syndrome, which is associated with gonadal dysgenesis. Short stature, widely spaced nipples is also important, and Hirsuit features an acne as in PCOS or congenital adrenal hyperplasia. Thyroid examination, pelvic examination can suggest rudimentary or absent uterus as in MRKH. Transverse vaginal septum imperforate hymen on physical examination, signs of virilization, and clitoromegaly also. So after taking the complete history and physical examination of a patient with amenorrhea, we look for the secondary sexual characteristics. Secondary sexual characteristics, if they are present, then we have to look for the uterus. So we have to perform the ultrasound. But if secondary sexual characteristics like breast development or the development of pubic hair is absent, then we have to measure them for FSH and LH. And this is the first investigation that we do in patients of primary amenorrhea. So if the secondary sexual characteristics are present and on ultrasound examination uterus is also absent, then the diagnosis of androgen insensitivity syndrome or Mullerian agenesis can be possible. So next investigation that we have to do is karyotyping. So if karyotyping is revealing normal karyotype of a female like 46XX, then the diagnosis is MRKH or Mullerian agenesis. While if the karyotype is 46XY, means there is no secondary sexual characteristics and also there is absence of uterus, then androgen insensitivity syndrome diagnosis is made if 46XY is present. Now if USG examination uterus is present, then we have to look for the outflow tract obstruction. It could be due to transverse vaginal septum or the imperforate hymen. Now the first part of the flow chart where the secondary sexual characteristics are absent and we have measured their FSH and LH levels. So if the FSH and LH levels are less, then the problem is at the level of either hypothalamus or pituitary, and this suggests hypogonadotropic hypogonadism, which is due to the causes of hypothalamus and pituitary. But if the level of FSH and LH are normal, means FSH is more than 20 and LH is more than 50, then this suggests hypergonadotropic hypogonadism, means the brain is sending LH and FSH in adequate amount, but it is not acting because the organs may be different or they are not acting working properly. So the next investigation here also, if the levels are normal and there is no menses, then we have to do karyotyping. And if the karyotype is found to be XO, then the diagnosis is Turner syndrome, and this can be associated with other dysmorphic features also. And if the diagnosis, if the on karyotype the genotype is XX, then diagnosis of gonadal or POI, also known as primary ovarian insufficiency, is made. Now we will discuss these diseases one by one. First one is the Mullerian agenesis, also known as Mayer-Rokitansky-Kutzner-Hauser syndrome or MRKH syndrome. The incidence is 10 to 15% and it is characterized by complete absence of uterus, cervix and the upper 2/3 part of the vagina. The normal karyotype is 46XX and they have normal ovarian function. They can be divided into two subtypes. First one is isolated Mullerian aplasia and second is Mullerian anomaly, which can be associated with other anomalies like skeletal anomalies, congenital heart diseases, hearing impairment, renal impairment, etc. And these Mullerian agenesis can be associated with the mutation in the WNT4 gene or HNF1 beta gene. Now how will you evaluate such patient? So on physical examination, because ovaries are functioning normally, so these patients can have a normal breast development, normal secondary sexual characteristic. But on pelvic examination, the external genitalia is completely normal, uterus is absent and vagina is having just one dimple. You can see in this image that a dimple over the vagina is present. On laboratory examination, XX karyotype is there, LH-FSH is normal, and when we do an ultrasound examination of this patient, then this will reveal absent uterus. An MRI is the gold standard for making the diagnosis, and in this image you can see complete uterovaginal absence with solitary kidney. So just one kidney is present and there is no uterus, there is no vagina, etc. And here also you can see the laparoscopic image where there is no uterus on the pelvic fossa, while bilateral ovaries can be seen. So these bilateral ovaries are present and they are connected to each other through this short stump of the fallopian tube, but the uterus is absent. The second one is the androgen insensitivity syndrome, where androgen is there but the receptors are not working properly. So the incidence is 1 in 60,000 women, and 9% causes of a primary amenorrhea are due to AIS or androgen insensitivity syndrome. This is an X-linked recessive disorder. Phenotype is female, genotype is XY, and it occurs due to mutation in the androgen receptor on measuring the testosterone level, because they are genotypically male, so there is normal to high testosterone level seen in these females. Now because testosterone is present but it is not acting because the receptor is mutated, hence this testosterone is converted to estrogen, and that can cause the development of breast as well as the pubarc. But because of the genotype XY, these females are slim and taller than the average females. Large breast with juvenile nipples are seen. Absent pubic or axillary hair, which occurs due to the presence of testosterone. Sorry, I have told that wrongly. Estrogen is not responsible for the development of pubic hair, it is testosterone. And because in these female, testosterone is present but it is not working, hence absent pubic or axillary hair, no acne or other signs of androgen actions. There may be inguinal hernia also, because in place of ovaries, testes are present which are undescended, so the scrotal sac are empty, and the external genitalia looks normal. Blind vaginal pouch is there, and absence of midline structures like uterus, cervix, etc. So testis is present in the females of androgen insensitivity syndrome, and the location of testicular gonads is variable. It could be intra-abdominal, labioscrotal, or inguinal in origin, and the testis removal is recommended after completing pubertal development, that is at the age of 16 to 18 years, and it is associated with enhanced bone maturation. Once testes are removed, treat with hormonal replacement therapy because the source of hormone is removed. Now incidence of neoplasia in these testes is around 22%, and the most common histology is Leydig cell hyperplasia, and the most common tumor that can be seen in these testes is gonadoblastoma. So the first image is showing a cadaveric image in which E is a vagina, which is blindfold vagina, and G is the presence of testis in these females. Now in other histopathology image, you can see the Sertoli cells and the Leydig cells also. So if the uterus is present and LHFSH are normal, secondary sexual characteristics are there, and on ultrasound examination there is outflow tract obstruction, then we will order an MRI to differentiate between imperforate hymen and the transverse vaginal septum. So what is transverse vaginal septum? It is the failure of canalization of the distal third of the vagina. So upper 2/3 of vagina and lower 1/3 of vagina are formed from different structures, and if there is failure of recanalization of the distal third of the vagina, and this failure most commonly occurs in the upper and middle third of the vagina, then the diagnosis is transverse vaginal septum. The patient usually presents after puberty with amenorrhea and cyclical abdominal pain, can present with hematocolpos and hematometra, but this does not bulge with Valsalva maneuver, while a bulge can be seen in case of imperforate hymen. Investigations that can be done are ultrasound examination and the MRI of the patient, and the treatment includes the surgical resection of the septum. Vaginal dilator should be used to distend the vagina until it is healed to prevent the vaginal adhesions and prevent obstructions. So the management is surgical resection of the septum between the upper and the middle third of the vagina. So this is the transverse vaginal septum. Uterus is present normally, and this is 1/3 and this is 2/3. So a septum is present at the junction of upper 1/3 and middle 2/3. This is known as transverse vaginal septum. And during puberty years, at the time of menarche, this patient can manifest as hematocolpos, and there is transverse vaginal septum which is causing an outflow tract obstruction. Now the another cause could be an imperforate hymen, which is the most common obstructive lesion of a female genital tract, and the classical appearance of bulging blue domed translucent membrane. This also can present with hematocolpos or urinary retention, and this differs from vaginal septum in that imperforate hymen bulges with Valsalva, while transverse vaginal septum does not. The treatment of choice is a cruciate incision that is made over the vaginal orifice, and this allows the collected blood to get drained out. So this is the pelvic examination that reveals an imperforate hymen, bluish hue due to the presence of blood, and it can be seen at the location of the hymen. And the management is a cruciate incision is made over this hymen for drainage of the collected blood. Now next is hypergonadotropic hypogonadic amenorrhea with the absence of secondary sexual characteristics. Means LHFSH is present, but it is not acting on the ovary because ovary is abnormal. So this can also present as primary amenorrhea. We have divided it into 4 types. Means no breast development, means high FSH, approximate frequency is 40%, 46XX 50%, 46XY 5%, and 46XO means Turner syndrome 20%. So, cause could be Turner syndrome or gonadal dysgenesis. Turner syndrome, the incidence is 2500 to 1000 live bonds, 1 in 2500 to 10,000 live bonds, and the cause is absence of ovarian determinant gene, resulting in premature loss of the germ cells. Fetuses with Turner syndrome has same amount of germ cell at the mid gestation as do a normal female, but as the gestation continues, there is accelerated loss or accelerated apoptosis of the germ cells, and many exo individuals lose all the germ cells prior to birth. Once germ cells are depleted, the only remaining tissue is connective tissue, and hence these females have streaked gonads, which is a characteristic feature of Turner syndrome. So this child is having Turner syndrome. You can see this child is having a short stature, characteristic facial features, and low hairline, webbing or folding of skin over the neck area, constriction of the aorta, depicting as coarctation of aorta, shield-shaped chest, widely spaced nipples, poor breast development due to less hormones in the body, short fourth metacarpal and metatarsals, elbow deformities, rudimentary ovaries also known as the streak gonads, and no menses, small fingernails, and round spats also known as nevi over the body. Coarctation of aorta in 30% of the patients can also have bicuspid aortic valve or mitral valve prolapse. So in these females, echocardiography should be performed every 3 to 5 years. This is very important. Renal anomalies includes an horseshoe kidney that needs retroperitoneal ultrasound once diagnosed, and hypothyroidism can also occur in 10% patients with Turner syndrome. So annual screening of thyroid disorders and antibodies is recommended. Now next disorder is gonadal dysgenesis, in which patient can present with a primary amenorrhea. The karyotype is like a normal female 46XX and refers to the number of conditions in which abnormal development leads to streak gonads. So the incidence is less than 1 in 10,000 women. Familial inheritance is 7 to 30%, and here we can find the pre-mutations in the FMR1 gene, which leads to fragile X syndrome. And there are certain autoimmune diseases which can be associated with gonadal dysgenesis, like Hashimoto's thyroiditis, Addison's disease, hypoparathyroidism, vitiligo, acquired diseases, radiation, chemotherapy, environmental factors, and the childhood viruses. Now, how will you make a diagnosis of primary amenorrhea? If the duration of amenorrhea is more than 3 months and FSH is in the menopausal range, then a diagnosis of gonadal dysgenesis or primary ovarian failure is made. Ultrasound detects 60% patients with undetectable ovaries by the ultrasound, and majority have no follicular growth. DEXA scan, in addition to screening for autoimmune diseases, is also done, because in these females estrogen is already low, so there will be a negative impact on the bone health of the female. So here we will advise her for DEXA scan and can start calcium and vitamin D supplementation also. Now what is the treatment? Because there is no hormone, so we have to give hormone replacement in the form of low dose estradiol 1 to 2 milligrams per day, and then we can step up for months before addition of progesterogenic agents. And if we want regular menstruation, then simultaneously we can add progesterone also. These POI females or primary ovarian failure females can become pregnant in 5 to 10% of the cases, will cycle inconsistently. Recommended OCPs to prevent unwanted pregnancies, and transdermal estradiol is better tolerated. Estradiol is given prior to progesterone because it allows the growth of the breast and the uterus, and in addition to hormonal replacement, these patients also need calcium and vitamin D replacement. The vitamin D is given in a dose of 800 international unit per day, and vitamin D with 1200 milligrams calcium per day. So another cause of gonadal dysgenesis is Swyer syndrome, where there is mutation in the SRY gene or the sex determining region of Y chromosome, which is present in these patients. And here also streak gonads are present. There is no testis formation there because there is mutation in the SRY gene. So testes are not formed, and hence anti-Mullerian hormone and testosterone are not produced. So female internal genitalia is formed like normal uterus and fallopian tube, and there is presence of female external genitalia also. Estrogen is also not produced because the gonads are streaked, and therefore breast development does not occur. These streaked gonads need removal as they are increased risk for germ cell tumors, and most common is gonadoblastoma. So in these females, uterus and fallopian tubes are present and the gonads are streaked, mainly testis. So these also mandates the removal of gonads, because this can cause gonadoblastoma, and because this is a gonadal dysgenesis, so the LH and FSH levels are high, but the hormones like testosterone and estrogen are low in these patients. So here there is a patient of Swyer syndrome. Dysgerminoma is occurring in these female in the streak gonads. Now hypogonadotropic hypogonadism or hypogonadotropic hypogonadic amenorrhea, where LH and FSH are low because the problem is lying at the level of hypothalamus or pituitary. Patient can present with no breast development because there is no LH FSH, though there is no testosterone and estrogen also. There is the cause can be constitutional delay, which is the most common cause, and the incidence is around 10%. Prolactinomas can also cause hypogonadotropic hypogonadism. In 5% cases, Kalaman syndrome, CNS lesions, stress, weight, anorexia, which is causing hypothalamic amenorrhea in 3% of the cases, PCOS in 3%, and other causes includes 4% of the cases. Now, what is constitutional delay of puberty? Puberty occurs at a greater than 2.5 standard deviations from the mean. Family history of delayed puberty is present in these persons, and characteristic features includes they are significantly short, bone age lags behind the age match controls, and they are often in the early Tanner stage, means Tanner stage 2. Gonadotropins levels are low, and the diagnosis of exclusion is constitutional delay of pregnancy after excluding the other reproductive disorders. Now coming to the first cause, constitutional delay, we have already discussed. We cannot treat that cause. The next cause is prolactinoma. Prolactinoma is the most common cause of pituitary related amenorrhea, and the mechanism is that elevated prolactin levels suppresses the hypothalamic GnRH secretion, and hence this decreases LH and FSH. Higher the prolactin level, the greater disruption of the menstrual cycle is there, and on imaging, MRI of the pituitary fossa will reveal a tumor also known as a prolactinoma. If the prolactin level is more than 100 nanograms per ml, or if there is a presence of headache or visual symptoms. The treatment is a prolactin inhibiting drug known as bromocriptine or cabergoline. 80 to 90% of the hyperprolactinemia will resolve with these drugs or the medical treatment, while 80% of microadenoma will shrink with these drugs and resort to transsphenoidal surgery if this medical therapy is failing. So this is a prolactinoma or a microadenoma in a size of 8 mm, which is micro, and this is in case of a 14-year-old female. Now, what are the other causes of pituitary amenorrhea? It can be tumors which presents as space occupying lesion, pituitary necrosis, systemic inflammatory diseases like sarcoidosis, tuberculosis, hemochromatosis, arterial aneurysm, which can cause shrinkage of the area that pituitary occupies, panhypopituitarism, hemochromatosis, and the metastatic tumors also. Now there is one functional hypothalamic amenorrhea which is very important, and in this condition the patient can present with stress, nutritional deficiency, or exercise related amenorrhea. Alteration in the normal pulsatile release of GnRH is there. Mechanism is complex interplay between neuropeptides, lower level of leptins leading to malnourishment and anorexia, and then amenorrhea. Cortisol levels are high, so this increase CRH, and this CRH is inhibiting GnRH. Exercise, chronic imbalance between calorie intake and consumption leading to hypothalamic dysfunction. So nutritional counseling is very important if a patient with chronic weight loss history is presenting to you. Now another entity is Kalaman syndrome, which is a X-linked recessive mutation in the cal1 gene, resulting in the lack of migration of GnRH neurons from the olfactory plug cord, and hence characterized by hypogonadotropic hypogonadism. There is absence of pubertal development, and there is primary amenorrhea also, because olfactory neurons are targeted. Hence patient can present with anosmia, midline facial defects, and in cases there can be renal agenesis also, because hormones are not there. So we have to give hormone replacement therapy as a treatment to promote sexual maturation, and fertility is possible using IM gonadotropins. So in this condition, what is happening, that olfactory placode neurons are not getting migrated, so the pituitary is lacking them, GnRH is not released, LHFSH is not released, and hence there is no testosterone, estrogen, so there is no development of sperm cells or the egg cells. So this we have already discussed prior. Let us revise this again. So if a patient comes to you with primary amenorrhea, so first of all you have to look for the secondary sexual characteristics, and we have seen if the secondary sexual characteristics like a pubarc or a thylarch is present, then we can order an ultrasonography. If on ultrasound uterus is present but still menses are not occurring, then there is outflow tract obstruction, and in these cases the diagnosis could be an imperforate hymen or a transverse vaginal septum. But if on USG uterus is absent, then we have to do the karyotype. So if the karyotype is normal, then the diagnosis is Mullerian agenesis, also known as Amenorrhea syndrome, while if the karyotype is XY, then a diagnosis of androgen insensitivity syndrome is made. Now on the second chart, you can see that the secondary sexual characteristics are absent, means there is no pubarc or thylarch, and hence estrogen and testosterone are absent, means hormones are absent. So if hormones are absent, then there can be a problem at the level of LH and FSH. So what we will order, if we will do an LH and FSH measurement of the patient. So if LH and FSH are low in amount, means the problem is lying at the level of the centermost point, that is hypothalamus and pituitary, and a diagnosis of hypogonadotropic hypogonadism is made. But if the LH and FSH levels are normal, so a diagnosis of hypergonadotropic hypogonadism is made, and again we have to do karyotyping, and if the karyotyping is normal and LH and FSH are high in amount but still ovary is not functioning, then this is primary ovarian failure, also known as primary ovarian insufficiency, which can occur. And if the genotype is 45X on karyotyping, then this could be due to Turner syndrome or gonadal dysgenesis. That's all.